get along without you very well. Of course I do.
Okay, so welcome to Nashville. I'm Dan Cole, the president of APSF, and we're excited to put on this conference. There's a lot of enthusiasm here, so welcome, and we look forward to a good day and a half here and get some action done. A little bit of housekeeping items. You've all figured out where breakfast is. That's where we'll have lunch also, so just go there. The restrooms are to my right. Dinner this evening, or the reception, is going to be outside, unless it's thunderstorming, by the fountain, which is kind of essentially real close to where we drove in. We do have Wi-Fi for this meeting. The network is APSF Conference, and the password is capital T, capital N, essentially Tennessee, 2022. And if I could have the slides. Let's go back one. So this conference is crucial patient safety issues in office-based and non-operating room anesthesia. I do want to take a moment to thank our sponsors, without which this meeting would not go on. You've seen the slide of them, but Medtronics, Merck, Fresenius Kabi, BD, Eagle, and Preferred Physicians Mutual. A couple of slides about APSF. We're an organization that depends on individual and corporate contributions, and thank you all for your support throughout the years. The more we get, the more high-impact activities we can do to actually ameliorate patient safety. Things that we do, here are our levers of action, and again, we try and focus our dollars and our energy, and we've got a lot of very energetic people with APSF. Our research, we've given over $15 million in research grants. Education, we typically have this meeting every year. I think we're around 20 or 21 for this Stoelting conference. We have started an outreach into international type meetings. We're holding a Malaysian conference. It'll be done virtually next year, and then we're starting to plan for an international patient safety conference that will be held in Tokyo in 2024. Our newsletter is kind of one of our flagships, so to speak, and it's read by over 650,000, maybe 1 million people each year that open it up in all countries that are listed by the WHO in the world. So it's very high impact. Something gets published in there, it has impact around the world. We collaborate. We're an organization that was put together I don't know, 35, 36, 37 years ago. We bring all the stakeholders of individuals that are interested in patient safety, which includes the ASA, the AANA, the Quad A. We have associations with NQF, ISMP, And then industry. Industry are very important partners. Very little would be accomplished in medicine, or very little advances without industry. And so we're looking for that partnership with all of the stakeholders that want to improve patient safety. We have a big social media presence, a website that's very active, and we've actually had some press releases and some press interviews. So we're trying to make some of our patient safety priorities high profile. And then we've gotten a little bit involved in advocacy. We have sponsored a bill in Congress on opiates. I'm not sure it's going anywhere this congressional season, and we're not a big advocacy organization. We don't have those particular competencies, but we have gotten involved where it's important. We've put out a lot of statements with ASA on COVID, and we recently had a statement on the criminalization of medical error. Brian Thomas, our next speaker, was the chair of that task force. And we've set aside 2 or 3 minutes. Elizabeth Rebello is going to give a lecture this afternoon on medication errors, and I've asked her just to carve out 2 or 3 minutes just to talk about that, even though it doesn't necessarily have perfect intersection with our topic. It is and has been something of interest. Our Stoelting conference next year, it's already starting to be planned. It's on disruptive technology, and I use disruptive in a potentially positive sense, talking about connected care. Jeff Feldman will be the chair of it. I think he's around here somewhere. Yeah, there he is, over there. So if you have any input, please see Jeff. But connected care, artificial intelligence, machine learning, telehealth, and microsensors, and we'll get a little bit of a glimpse into the future of that in the session tomorrow morning as far as that goes. But it should be extremely interesting. This technology has great potential to improve patient safety, but if done wrong and not adapted correctly, it has the potential to do some harm. So we want to be in that conversation, from the beginning. And I go back, the original founder of APSF and the president, Jeep Pierce. I go back to let me paraphrase what he wrote decades ago, but it's like running a marathon or maybe climbing a mountain without a clock, patient safety. It's a commitment. We're not going to solve it today, but we do want to take real action that improves patient safety. Patient safety is not a fad. It is not an objective that has been fulfilled. It is an ongoing necessity. It must be sustained by research, training, and the daily application in the workforce. So that's kind of the motto we live by. If I can use a sports analogy, we're not at a place where we spike the football in the end zone. We're continually making first downs, so to speak. This is the planning committee. You'll see them, and my thanks to them. And this is a great time to thank Stacy Maxwell, our administrator, who's put a lot of work into that. So thank you to the planning committee and the speakers and you, who are going to have a lot of input into the recommendations that come out. I borrowed this slide from Emily Methencool, your first moderator, after Brian speaks. But this is a slide essentially detailing kind of the root causes of increased complications in NORA. And you can see we've identified 6. There could be more, but location, ergonomics, equipment, team, distractions, and production pressures. And I can't tell you how many times I've heard from people, and certainly I've experienced, where you're doing a critically important procedure in some place miles away from the operating room, or it seems like miles. You're crammed into a little corner where you can barely turn to open up the Pyxis. The Pyxis drawers don't open up easily. It's dark. You're trying to read a very small print, which becomes harder and harder as you get older. And there's wires across there, which would be very easy to kind of trip on. You're working with new people that you don't necessarily work with, so the teamwork actually becomes a little bit harder. And then you're trying to do things quickly, which we're all trying to do. So there's a lot of things that we can work on in NORA, I think, to improve patient safety. And with that, I will transition to Brian Thomas. He's an attorney. He's on our APSF board. He is the Vice President of Risk Management for Preferred Physicians Mutual. Brian.
Thank you, Dr. Cole, and good morning and greetings to everyone, both here in person and our virtual attendees. Dr. Cole asked me to get us going this morning with some closed claims data. Again, I am an attorney. I work for a professional liability insurance company. Get our slides back, please. And I titled this presentation, Out of the Operating Room into the Courtroom. And we're going to look at some loss data that reflects some developing loss trends as it relates to NORA cases in the legal arena. For conflict of interest disclosures, again, I'm employed by Preferred Physicians Medical. I have no other conflicts. So let's just dive into the data. We looked at our last 200 closed claims dating back to January of 2010. These were all settlements. None went to trial. And as you can see from the pie charts, the NORA cases, which include endoscopy, cardiac cath lab, interventional radiology, imaging, office-based surgery, and then ECT is how we categorize the NORA procedures for purposes of this lost data. As you can see, about 14% of the total of those 200 closed claims were comprised of NORA cases. The pie chart on the lower right represents the total indemnity, and indemnity is the money that the insurance company pays when we settle or if we go to trial and we get a plaintiff's verdict. And I think this graphic is actually the most impressive with regard to the amount of money that these cases are resolving for or being settled for. As you can see, we're approaching almost twice the amount for NORA settlements as we are for our OR procedures. The other non-OR procedures would be labor and delivery, pain management, and ICU, airway rescues, tube exchanges, things of that nature, but we've carved those out from our NORA cases. Developing loss trend that we have identified during about that same time period of 10 years, including COVID, which of course skewed those data a little bit because of course most, if not all, elective surgeries were paused for a couple years or so, but we've gone back and looked basically at the last 10 years. And what we've identified is that endoscopic sentinel events comprise 10% of our overall losses during that time period, which is about $88 million. So as you can see, we've had 12 closed claim payments in the last 10 years involving catastrophic brain injury or death, resulting in about $8.5 million in settlements, and defense costs approaching about $1 million. That's a significant amount of money for a relatively small number of claims. And again, these cases are settled, and we'll talk about some of the challenges of why they're settled rather than going to trial and letting a jury decide the outcome. We also have 4 pending lawsuits involving endoscopic sentinel events that include brain damage or death, and we've reserved, or in insurance jargon, set aside about $2.5 million based upon our evaluation of those cases and our ability to defend them, which again is extremely challenging for a number of reasons. So I want to take a look at an actual case study. This is probably a case for the clinicians in the audience that you see on a routine basis. This is a 64-year-old gentleman, ASA 3. He had multiple comorbidities, including a BMI of 44. suspected OSA. His wife indicated that he snored loudly and had periods of apnea during the night. Diabetes, hypertension, came in for an elective colonoscopy. Again, probably someone that you see and treat on a routine basis. This was a MAC, propofol sedation with nasal cannula. During the procedure, the gastroenterologist noted an irregular heart rhythm, followed by hypotension, and then quickly followed by bradycardia. They turned the lights back up, noted the patient appeared to be cyanotic. O2 sats were at 75, continued to reduce into bradycardia, and then turned to asystole. They called the code, resuscitated the patient. Unfortunately, he never awoke. 4 days later, the family removed supportive measures, and he passed. Upon autopsy, the cause of death was determined to be hypercarbia, cardiac arrest, and anoxic brain damage. So, what were the expert criticisms in this case? So, there were numerous. Failure to secure the airway with an LMA or intubate the patient due to his high risk. And I think it's important to note that the criticisms weren't that the case wasn't started with a secured airway, but the failure to recognize the ensuing crisis and responding more quickly. Failure to use capnography or any charting of end-tidal CO2. That was a significant hurdle for us. As we know, that is required for moderate and deep sedation. There was no evidence that that was being monitored in this case. Failure, again, to recognize and treat the hypoventilation in a timely manner, and an overall lack of vigilance. But the evidence, or the anticipated evidence, was the gastroenterologist anticipated testimony. He told his attorney that if they take my deposition, this is what I'm going to say, and that was that the anesthesiologist was, quote, not paying attention, talking too much, showing pictures of his grandchildren on his cell phone. So this case, again, underscores quite a few of the topics and the themes that we're going to our speakers are going to address today. And as you can see, this case, while challenging on the medicine alone with the lack of evidence of end-tidal CO2 monitoring, became indefensible with the anticipated testimony that the anesthesiologist was distracted with his personal cell phone. This case ultimately settled for policy limits, which it was $1 million in this particular case, and our defense counsel essentially told us that we had a 0 chance of prevailing if we took it to trial, which again reinforces why these cases settle rather than go to court and let a jury determine the outcome. So what are the common allegations? And again, I think these are going to be touched upon by many of our speakers today, and as Dr. Cole has already noted, some of the root causes of these NORA catastrophic outcomes and injuries, and that includes inappropriate patient selection for the planned procedure at that facility, inadequate pre-anesthesia assessment, lack or insufficient supply of necessary equipment, staff, medications, lack of familiarity with that particular facility, the proceduralist, also failure to communicate with the proceduralist, distractions, as I just mentioned, the non-clinical use of the personal electronic device in the case study that we just looked at was significant in our evaluation and our inability to defend that care, and again, a lack of vigilance. So I've mentioned the challenges of defending these in court, and again, these I think were all underscored by the case study that we just looked at. So substandard care in that case, again, the non-clinical use of his cell phone, showing pictures of his grandchildren instead of paying attention to the monitors and the patient's vital signs. Also, the lack of capnography or any evidence that end-tidal CO2 was being monitored. Those were significant criticisms by the experts who looked at this case. Metadata evidence, and again, we could do a whole presentation on personal electronic device non-clinical use in patient care settings, but please understand, as I know most, if not all of you do, that whenever you use that device, it leaves basically crumbs and fingerprints of where you've been, URLs, and the plaintiff's attorneys have been very adept at identifying cases, getting others to point fingers, which is another challenge by other members on the OR team, in particular if the individual is distracted or they're perceived to be distracted with their personal electronic device. They can get forensic experts to look at those devices and/or subpoena the phone records and the other metadata that can then be laid against the medical record, and it's very powerful evidence that the individual anesthesia professional was distracted during the case. Lack of expert support for all the reasons that I just mentioned, and I think one of the most significant challenges is the potential jurors' perception that these are safe or easy cases. Everyone knows someone likely in their family, if not themselves, who've had a colonoscopy. These are elective procedures. You're supposed to go in. It's a 15, 20-minute procedure. You go home, might even go back to work that day. And then when you have a catastrophic outcome like brain damage or death, jurors just will not accept that those kinds of injuries can and do happen absent somebody's negligence. And then again, the increased risk that if we take it to a jury and that evidence inflames them, makes them angry at the providers, there's an increased risk that the verdict might actually exceed the available insurance policy limits, which none of you as clinicians ever want to be in that position. Excuse me. So what can we, as a professional liability company, do to help reduce and mitigate these types of injuries? So from an underwriting perspective, we have very stringent underwriting criteria when we look at a physician or a CRNA or a group of anesthesia professionals, and we try to identify what type of practice are they engaged in. Are they doing a lot of NORA cases? Are they doing a lot of office-based? Not that we won't insure them, but we want to gather a lot more information and make sure that those settings are appropriate and have all of that necessary equipment and resources that I mentioned. And like today, we're identifying loss trends. We get that data, we share it with the Closed Claims Project, with the ASA and the AQI. We've been doing that for, gosh, as long as my company's been around, for about 35 years. So we work closely with the Closed Claims folks and the AQI, and we share that data. And then we use it, obviously, for our own policyholders and insureds to make sure that we're identifying these loss trends to get out meaningful risk management advice and guidance and strategies for them to try to mitigate and avoid these types of losses. We also work with the groups. If we do identify a facility, for example, that doesn't have the necessary resources, medication, staffing, and then we will help them advocate for that and try to implement best practices and policies to try to avoid these types of injuries. And then finally, participate in focused risk management resources and strategies. Obviously, our participation at the Anesthesia Patient Safety Foundation is a big part of that. I mentioned the Closed Claims Project, and also bringing to bear human capital and corporate funding for patient safety organizations such as the APSF. And with that, I thank you for your time and attention this morning.
Well, thank you, Brian. And Brian will be available for questions, obviously at the break, but we'll add a chair to the dais here for the Q&A. We've already discovered a safety hazard, these chairs. Unless you're over 7 feet tall, they can be a little challenging to come. So during the break, we'll probably switch them out with some of these more reasonable chairs. I did want to make one more housekeeping announcement. Stacy has flash drives with the 6 APSF fire safety videos. George Shapiro has had a long passion for these and has worked hard. I believe we have 6 different languages on the flash drives. Is what? 2 languages. Okay, and then we're going to add French. Will be at the ASA. So please feel free if you're interested in picking up the flash drive. I would like to introduce our next moderator, Emily Methencool. She's Associate Professor at UCLA and Vice Chair for Quality and Safety. And we look forward to her panel. Emily.
Can everyone hear me okay? All right. Good morning, everyone. I have the honor of being your moderator for this very first session. So I'm honored to introduce an excellent panel of 6 speakers, all of whom are going to be discussing how to deliver an effective and safe anesthetic in these non-operating room locations. So for the first panel of speakers, as I announce your name, please come up and have a seat right here. Our first speaker, sorry about that. Our first speaker will be Bassem Abdel Malik. He is a professor of anesthesiology at Cleveland Clinic and leads efforts for anesthesia and bronchoscopy and oversees procedural sedation. He's the past president of the Society for Head and Neck Anesthesia, the Society for Ambulatory Anesthesia, and the Ohio Society of Anesthesiologists. And he'll be defining NORA as well as introducing some safety concerns. Brent Dunworth is our next speaker. He's the Director of Advanced Practice, Chief CRNA, and Assistant Professor of Vanderbilt University. He has won several teaching and leadership awards and is a Fellow of the American Association of Nurse Anesthetists. So he will be discussing space planning for safety and efficiency in non-operating room anesthesia. And Diana Inca is our last speaker for this very first session. She is an assistant professor of anesthesiology and the director of non-operating room anesthesia at Weill Cornell. She has expertise in cardiac and thoracic anesthesia as well as anesthesia in off-site locations. So she'll be describing some best practices for working with proceduralists to improve patient safety. Bassem, would you like to go ahead and get started?
Well, good morning. Thank you, Dr. Cole, for this kind introduction. I would like to thank the organizing committee for inviting me here to be with you, especially Dr. Cole and Dr. Ehrman. I'm very pleased to be able to share some stuff that I near and dear to my heart with you. So I was given the title of Defining NORA and Introducing Safety Concerns. So let's see if we can do that in the next few minutes. So these are the objectives, defining and also listing some of those concerns. Before I start, I want to declare conflicts of interest. During the last year, I've been a consultant and speaker for Medtronic and Acacia Pharma. And I've been also past president of the Society for Ambulatory Anesthesia a couple of years ago. And you see from our logo and the tagline in the bottom, NORA is one of the 3 main things that SAMBA addresses and cares for and will focus our energy and effort on. So how do we define non-operating room anesthesia? It sounds silly, but since we all do it, but I just wanted to make clear that this is different than other entities of our professional activities. So it is any anesthesia service, and the key word here is anesthesia service provided by anesthesiologists, nurse anesthetists, anesthesiologist assistants in areas away from the main operating room. This is to be differentiated from procedural sedation that's done by mostly moderate conscious sedation done by the proceduralist aided by sedation nurse. Also, NORA, which is an extension of our operating room activities, is different than our practice at the ASCs, as well as the office-based anesthesia practices. So these are 3 different entities. Each has its own challenges, has its own issues that we need to address carefully. The old term for it is remote anesthesia. That did not gain a lot of popularity since remote has a negative implications, out of sight, out of heart, out of mind. And out of operating room anesthesia, ORA, so NORA sounded much better. That's why NORA got a lot of adoption by most of us. So these are a list of some of the locations that you're all familiar with. Mostly, obviously, the busiest is GI and IR and bronchoscopy suite and many others, and the list goes on and increase almost in bi-weekly fashion or so. If you are in a busy practice, whenever they hire a new physician, they call you to was interested to start service in another area. We recently described NORA practice in ICUs. So part of the reason NORA exists is what causes the challenges and the complexities that we are facing when we take care of patients in NORA. Some of them are, the reason that we're doing a lot of NORA is that new advances in procedures where a lot of complex equipment that are hardwired in those areas that cannot be moved to the OR, and also the fact that they don't require full capability operating room. But more importantly, that the higher risk patients that were not considered surgical candidates in the past now have an option, having a minimally invasive procedure that can be done in a non-operating room procedure that does not make them as simpler cases or simpler patients. It just adds to the complexity of it. Also, the economic trends by for the push doing more outpatient, and also add to production pressure, as was alluded to earlier, adding to the potential risks in those areas. Again, I wanted to clarify that procedure sedation is different than anesthesia services, and I'm going to add that at the end as well, just to make sure that we're all aware of what we're talking about today, so as when we come out of here, we're going to have focused recommendation on non-operating room anesthesia. You might see the slides coming up in many other presentations, but as you see here, Erman and as well as Dutton showed us that what we know that the age of those patients is going up, those coming to NORA, as well as the ASA physical status, and the numbers keep going up, so the challenge is getting bigger and bigger as time passes. When I talk about NORA, I categorize the risks into these 5 categories. Space, and I will not discuss all these issues because I don't want to steal the thunder of the coming esteemed speakers. You're going to hear from them about space, you're going to hear about staffing issues, you're going to hear about patients, you're going to hear about the challenges with procedures. I will touch a little bit on equipment and monitoring, as was alluded to earlier, as a big problem in non-operating room locations. Not all NORA locations are created equal. Every area has its own challenges, and I picked out some samples because of the time that we have. In GI NORA, you see the challenges of monitoring ventilation is a big deal, airway management, and the decision whether to intubate or not, or prone position and such, MPO status. With the introduction of the split dose PrEP, the gastroenterologist allowed the patients to take the PrEP in the morning of the procedure, a couple of hours before we start working on them. Bowel insufflation and physiological changes with that. And the increased number of LVAD patients as they developed von Willebrand disease, and then they start bleeding, and the first thing they do when somebody's having a little bit of anemia, upper and lower GI, and you all know the challenges with LVAD patients. Many other challenges we deal with, hypovolemia, anemia, and the potential complication, perforation, aspiration, and such. So all these are challenges in gastroenterology. I picked another example, IR. This is one case where this lung cancer patient was coming for cryoablation of a lung mass, and the procedures has to put in those four probes. Excuse me, I'm sorry. Those 4 probes that would go through the anterior. Complication of those probes, where it could cause pneumothorax, the freezing of lung tissue, and thawing may result in parenchymal hemorrhage and such. So not only we had to put arterial line, but double lumen tube in the CAT scan suite to take care of this patient. So lots of challenges out there. Obviously, I could talk for hours and days about my most favorite NORA location, as you all know, bronchoscopy, but I will save you that. Basically, lung cancer patient, terminal lung disease patients coming for invasive procedures in airway. What do we know about the data? We have heard some a little bit earlier from Brian, but this study in 12 million NACOR patients showed us that the patients are older, and we do a lot of MAC cases in NORA. But more importantly, that they identified that in cardiology and IR, the mortality is much higher than the operating room suite patients. And also identify another area which is concerning, that the wrong site and wrong patients, something that is a big deal in the NORA location. And this is an area where we can shine. We can take the skills that we learned in operating room and using checklists and such to minimize that risk in non-operating room anesthesia as we go practice there. So in this closed claim study, they showed us something that in those MAC cases, that respiratory depression was responsible for a lot of issues that happened there. The sad and good news is that over half of these cases were judged to be preventable. It is sad because it should not have happened to start with, but the good news is that we can do something about it, and we know how to handle that and manage it. Here's another study that showed that the same thing, preventable cases by monitoring in NORA were very high, and respiratory events are even higher than the OR. And we can see that, as we have seen earlier from Brian, that more death happening in NORA and more payout as well for those cases. Each single one of these cases should be looked at in details. We should do a robust quality review process. We should look at why did this happen with this particular case, and we're able to provide safe service to the other thousands we take care in that area. We need to dissect that event, find out what happened. Any lessons learned should be disseminated to the rest of the group so as we can help prevent that from happening again. This is an article that I wanted to share with you where we have addressed many of these issues with non-operating room anesthesia as we establish this bronchoscopy suite. And I'm here to learn more from you as we go through today and tomorrow, so as we can take some of those lessons back and further improve on what we have accomplished there. But here's some examples of things we have done. What we did is that we started, as we planned the place, we started from the blueprints. I got together with the pulmonologist and decided where we're going to have the patient directed at, where we're going to have the anesthesia machine with the bronch tower, the anesthesia supplies, and so forth, starting from the blueprints. And now you can see what the results are in this bronchoscopy suite. When we start functioning clinically, it became an area of excellence. And the place that used to be a much hated assignment for our teams and considered a burden that we had to share. Now I'm having difficulty meeting the requirements. A lot of people want to go work there. They feel safe because everything that we wanted to have there is there. All the monitorings that we wanted to be there are there. The structure of the place similar to what we have in operating room, the same anesthesia machine, the same supplies, the same Pyxis machine with medications and so forth, and the backup supplies and phone to call for help and so forth. This is one of the reasons we do not like to work in NORA, is that we do not have what keep us or what make us feel safe as we can provide safe care to our patient. Not because we hate the place or hate the services, just because we don't feel a little safe and make us a little nervous. We replicate the process in GI suite, and you see as well as IR, as well as surgical MRI, the so-called MRIS. And the issue is that it's not the beginning of the care, but as we heard earlier, it is a marathon. It is a marathon that we have to continue going. So these areas, oftentimes with advance of technology, they start bringing in new procedures and new equipment. And we need to be very familiar with it because unfamiliarity may introduce some risks to it. So for example, when we introduced the robotic bronchoscopy to the bronchoscopy suite, even though it's a well-run area, very safe, efficient, and so forth, we had to bring the team together where we did a dry run. So we brought the scope, we brought put a mannequin and hooked the mannequin to the scope. You could see the arms are actually hovering over the airway and so forth. And everybody had to be familiar. All team members were involved, the anesthesiologists, nurse anesthetists, the bronchoscopists, the bronch suite nurses and respiratory therapists, everybody was there. We anticipated emergency. What happened if the patient gets pneumothorax or bleed? Who's going to disconnect the robot from the airway, from the tube? Who's going to move the robot back, and who's going to do things, and how we're going to get quickly into the airway and manage that complication. And once we set up rules and assigned rules to different team members, and we were able to execute the procedure safely afterwards, and we do many of these currently. So again, NORA versus procedural sedation. The risks and issues and safety concerns in NORA not only involve the anesthesia services, but also involves procedural sedation. Why do we care about procedural sedation? Guess what? We are responsible for it as well. CMS mandated that the anesthesiologist, the chair of anesthesia, has to have oversight over procedural sedation, and that's why we need to be involved in that and ensure safety. Here are some of risk predictors, as Dr. Ehrman and his colleagues shared with us in an example in IR suite. And these are factors that we can look into to consider for patient selection as they present for procedural sedation versus anesthesiology services. The simple concept that all of us here as anesthesiologists, nurse anesthetists, anesthesiologist assistant know by heart and practice daily, like the difference between oxygenation and ventilation, the two components of respiration, are kind of not very well understood and appreciated by our procedures colleagues and their sedation nurses. So that's an opportunity for us to teach and help them to understand that the issue is that even amongst us that we know this very carefully and we know it very well, we still downplay the importance of that, and sometimes we do not use the proper monitoring or do not watch it closely and so forth. So for the two different things, NORA as well as procedural sedation, we need to pay close attention to this concept and the need for monitoring ventilation and oxygenation. There's lots of things that we can provide and help our colleagues when they provide procedural sedation and provide it safely. Our group published this article a few weeks ago in Anesthesia and Analgesia, where we listed some of the initiatives that we have done and the education, training, and teaching and monitoring and quality and so forth that have helped our organization to provide safe sedation to almost about 100,000 cases a year at the main campus and related ASCs. With that, I conclude with the summary that NORA is here to stay and is growing fast and its future is bright. There's lots of challenges, lots of risks, lots of issues with NORA, but there is nothing that we cannot overcome. And the big example is us here together today and tomorrow, where we can discuss these issues and hopefully come up with some practical solutions that we can all apply. With that, I conclude and thank you for the opportunity.
Thank you very much, and good morning, everyone. Appreciate the opportunity to speak here at the APSF. I'm going to talk a little bit about efficiency and space planning when it comes to suite design in non-operating room spaces, and really the impact that we can have at that table. And so we'll talk about the challenges we have with existing hospital infrastructure and how we design, right, and build out NORA spaces. We'll talk about suite design and how it may relate to anesthesiology outcomes, and then really talk about opportunities for safety enhancement during renovation and new construction in particular. So in many locations, the NORA areas have been sort of set off by themselves, and anesthesiology services have sort of been added on at a later time in the history, right, of NORA. And that's because our ability to really improve the efficiency of sedation has proven its worth, I think, and also the fact that we can really get patients to a quicker, safer, deeper level of sedation for procedural needs. But we sort of get brought into the picture and say, well, these are the suites, and oh, you have equipment to bring with you? I guess we can probably find a space for it. We'll put you back in the corner, and that should be good for you to do your work. And so one particular shortfall is that our services have been bolted on over the course of time, and so really not planned from the inception of particular non-operating room spaces. So we're often space constrained. I think that's a major reason why providers don't love to go to these areas sometimes, because they just feel as though they don't have the right ability to access, medication drawers, as we've heard already, potentially the patient as well as get help when necessary. Is there access in an emergency, and what is that plan? And so if you're in the interventional radiology suite and major bleeding is encountered, how do blood products get to those areas? That may be not something that the staff in that area is familiar with doing on a regular basis. Equipment limitations. Do you or do you not have an anesthesia, for example? And so not all of the NORA areas have them. Not all of them necessarily may need them. But what are the limitations when you don't have one, and what is the backup plan in that particular situation? We have a lot of procedures where field avoidance is necessary, and some situations that I'll describe a little bit later where field avoidance is sort of something that has become the way that we do things and maybe not the best way we do things, so we'll touch on that. But not having easy access to the patient's airway can be concerning. And I sarcastically use conventional wisdom here that the endotracheal tube is too invasive. And so when these conversations come up, there's still, a feeling out there that, well, general anesthesia is a lot more than we need. We probably just need a little bit of propofol. Or, it'll take too long if we put an endotracheal tube in. And these still persist, and we can get past that through good relationship building and communication, and certainly patient advocacy. Other shortfalls, again, emergency preparedness, is there a code button? Do they work? And where does it respond, and who will come if you press it? Do staff in the areas know how to manage emergency situations? And that really, you can get really a long way with some education. I have found that a lot of the non-operating room staff are thirsty for the knowledge of how can I help when things go wrong, and building that in relationship in terms of a 30 or 60-minute staff in service to them really empowers them, and they start noticing. And I love when the saturation dips a little bit and the circulator in the room says, hey, do you need anything, are you okay? That they're really paying attention to that and anticipating how they may help us when necessary. And then what about equipment? What do we have in these areas? Do we have the appropriate standards of care that emulate what we're used to in the operating room space? So, what's on the emergency airway cart? Does it exist? And hopefully the answer to that is yes. But is it modeled in the same way that we're used to seeing in other areas of the hospital, so that when you need to use it quickly, it's familiar to you in terms of where we find things? The code cart, is it available? Where is it located? Who gets it? And then, of course, do we need invasive lines or blood and fluids? And how is that addressed in the rare events that they occur? And of course, we always stumble when we are trying to do something that is very familiar to us, right? Blood transfusion is one of those things, but in an environment where not knowing how we get the blood to the room can be a problem. And of course, as we've heard already, the location of these suites in the hospital can be challenging. And so if you're calling for help from colleagues, we have some folks that wouldn't know, right, where the GI lab is, and that we have 2 GI labs, and that they're located next to each other and not particularly easy to get to. So those are some of our shortfalls, but I think that the opportunities become readily apparent when you have construction and renovation activities going on within your hospital. And so it is not the sexiest committee to get involved in, but I will say that it is really one of the more rewarding things that I have been involved in, because you can really have an impact on the future of the safety of these particular areas. And you can really engage in a lot of conversation with folks who don't really deeply understand all the work that we do as anesthesiology professionals. And so when you have the ability to sell, I think, our collective professions, I take the opportunity at every moment to do that. So what are some of the things that I've learned in my opportunity to participate in these different planning meetings? The first one is getting invited. And that might mean inviting yourself. So it may mean crashing the party, potentially, depending on how you want to look at it. But a lot of the time, these projects will get started in hospitals and ambulatory centers and what have you. And they forget to add us to the invite list. And I don't think that it's intentionally being exclusive. I think that we're all just moving at such a fast pace that, we think of our local colleagues and put them on the list. But when I find out these are happening, I usually make a phone call and say, hey, I hear we're talking about renovation. When are those meetings? I'd love to come. And I found that then I do get invited and then represent the department very well at that level. Building relationships becomes important. And I don't think that, people don't appreciate, what we bring to the party in terms of safety and care delivery. I think they know that pretty well. I think we're so good at it, actually, that it's a bit of a disservice, because we just look so good at what we do. And we do it so easily that it appears to be easy, and people think, well, as long as there's a supply of propofol and syringes, and I guess we'll give you an ambu bag, you should be good to go. And of course, we all know it takes a little bit more than that. And so discussing that goes a long way. And when you're having discussions in planning meetings, really keeping the main thing of patient safety can help when there are differences of opinions. And so that always sort of brings us back to center to say what is the right thing to do and how do we serve our patients best, right, for safety and for efficiency, as well as provider experience as well. So keeping safety, ergonomics, and efficiency at the forefront of the conversation goes a long way. I get nothing but frustrated if I'm working in a space where I can't open the anesthesia machine drawer and the medication drawer at the same time, right? Because they hit one another, and so we can certainly do better than that, especially when there's a crisis and others have to help. You might have to repeat steps 1 through 4 many times and have many conversations, and sometimes those conversations go outside of the formal meetings to get where you want to go. And then once you help to design these suites in a way that really helps with form and function, right, it needs to be hardwired at ribbon cutting, and I'm going to give you sort of an example of that. So these are a couple examples of sort of what we have and what we've built. And so this is the then GI lab area, and this is just 302 square feet, which is pretty narrow. And I think the photo doesn't even do great justice to this, but you can see there's just enough room to get a stretcher in, and that's about it. And it's very difficult to get around the stretcher when the procedure's in process. It can be done, right? But you usually bump into things and hit your head on things, and again, reasons why people have some degree of frustration. And there's also, in this particular suite, right, all the equipment is floor-based, and so it rolls on the floor. So the ability to move the equipment around, if you're going to do a colonoscopy followed by an EGD or vice versa, is almost impossible. And so what we found ourselves is anytime that you're doing an EGD in these rooms, you have immediate field avoidance because the patient's head is 180 degrees away from you, which is certainly suboptimal for airway management in a challenging procedure where you're sharing an airway and probably need a little bit deeper anesthetic than perhaps for a colonoscopy. So that was my passion as I went into these meetings, to say no more field avoidance, right? Especially with upper endoscopies, we can do better than this. And it took a lot of relationship building over the course of time, and so we opened some new suites that are 444 square feet, give or take, with a tremendous amount of space around, right, where the patient is. And you can see the equipment is now ceiling mounted. And so I lobbied very hard to say, okay, well, no more field avoidance. If you're going to do, an upper and a lower, then you can just swing those things around, right? And they all looked like, well, yeah, I guess we could, which meant that, well, we don't really want to, because we just like the way we're doing it. I said, well, I really think this is going to be important, right, to how we deliver care. And so at ribbon cutting, I made sure I was there on day one, representing the work of the anesthesiology department. And there was, right, a patient scheduled, thankfully, for an EGD and colonoscopy, and the proceduralist was on the planning committee with me. And so it was like, okay, well, we'll have to bring the patient in the other way and then turn them around. I'm like, no, remember, we're going to move the equipment. And then you could tell they're like, oh yeah, that's right. We did talk about that. And there was a real regression to say, well, that just seems like it won't work. And I said, I think we really owe it to ourselves to try this, right? We've planned it. I think that we know that patient outcomes are better when the airway is near me and all my tools. And so let's give it a try. And lo and behold, it was quite successful, right? And that's how it became hardwired, because I think if I hadn't been there on day one, fighting it backwards would have been very difficult. And so everyone's very satisfied. And when you build these suites in their space, it really changes everyone's perspective on their desire to work in those locations, and we make it as standard as we can just like our operating rooms, as you can see, with automated dispensing systems and the like. So, thank you very much.
Good morning, everybody. Thank you for the opportunity to speak at this great conference. And I will be endeavoring to talk about working collaboratively with our proceduralist colleagues to improve patient safety. I have no disclosures, and those are my objectives. And I'm going to start with something that probably all of us have seen, our case scenarios, either a difficult, potentially disastrous airway, a potentially significant complication, potentially high mortality, or your new suite, building on what my colleague said, you're building a new suite, new equipment, and or your hospital is being approved for a heart transplant program. So all those are things that we might face in our practice, and they all have in common either complex patients, complex procedures, potential for significant complications, multiple teams involved in care, new suites, new programs, new procedures, and we have a seat at the table. And I know my colleagues have addressed that. Looks like we're all on the same page. We all know the challenges of facing NORA, and as Dr. Cole mentioned in the beginning, I will throw in the curveballs, because there are multiple papers, as we know, about the pitfalls of working in NORA locations. And they all outline increased mortality, morbidity, and the close claim data. But here are the curveballs, as I call them. Procedures in non-operating room settings are different than the main OR. Oftentimes, it's diagnostic and procedure into one. Think of your EP study, possible ablation, possible device. We won't know until we do the EP study. Or your angiogram, possible embolization, or your EGD, there might be a clipping or a variceal banding and so on. So planning from the get-go, it's not as simple. Equipment is complex. We don't have the main OR tray as we have in the main OR, but rather radio frequency, navigation, robotic, bronchoscopy, ultrasound, and they tend to be sensitive and shut down when the temperature in the room goes too high. Staffing, well, perhaps it's not the place you want to send your most or newly hired attending after a month of being on board. And they are unpopular, right? How many times have we heard, I've been to IR last week, why me again? Or GI, okay, why doesn't everybody in the department go to GI? Why is it just a group of us? I will add to this something that's not on the slide, and the fact is all those locations are widely different from one another. If you think EP, NIR, and GI, they're not the same. EP has their own equipment. IR has CAT scan and fluoroscopy. Add the robot, the stereotaxis in EP. Even each location, each suite has different settings and setup, as Brian mentioned earlier. Angio 1 is different than Angio 3, so they're not all the same within the same location. So talking about the players involved and what are our goals, and we're talking about proceduralists, we're talking about anesthesia team, technicians and nurses, and of course administration. And when we look at goals that we have, we all know that we all want a safe procedures going smoothly, efficient, no conflict. But each of them have their nuances. A proceduralist, and I know there are our colleagues speaking later, they want a still patient, not a moving target, and also they want time to teach their trainees. We want a clear plan. What exactly are we doing, and what's plan A, B, and C, and if we run into trouble, what do we do? We want the complex cases done in the morning, not at 5 o'clock when the team on call takes over. And we like to finish the schedule early, not to burden the team on call. Well, nurses, they have their own goals, and they prefer we get involved. It's easier, it's more controlled. They also don't want to go over time and prefer to finish the schedule early. And then there's the administration. For them, it's out of sight, out of mind. Bassem, I think, used the same, basically, they don't want conflict. They don't want additional cost. Budget is important to them. So where do we align all of those common goals, and is the recipe for success? And I call it the 3 C's: communicate, collaborate, coordinate. And it sounds a cliche, but basically this is what it is. There are papers. This is a paper from 2013 by American Heart Association Council on Cardiovascular Surgery and Anesthesia, reinforcing the human factors and teamwork. And I put it for electrophysiology because it's part of NORA. And our own Dr. Metan-Cole and Dr. Uhrman discussed exploring the opportunities for teamwork, emergency drills and stimulation, protocols and pathways, having a director of NORA to liaise with everybody involved, and combine conferences. Simulation has been around for a while, and I think it's important that more and more hospitals are doing this. But what's important is to get all the players on board. Everybody has a point of view. They have their own leadership structure, so it's important to have standardized patients. But if I have to put my best advice on this, not do it on a sim lab. This is not a simulation that you want to do in a sim lab, but rather on site. Again, because EP, IRGI, they all have their different procedures area. So don't do it on a sim lab. Get everybody involved. Make sure the schedulers know and allow block time to allow for that. And then debrief at the end. We are, and I'll speak later about what we're doing at our institution, how we are planning to do our simulation sessions. Talking about protocols and pathways could be for complex patients, such as an LVAD or pulmonary hypertension, or complex procedures, high-risk VT, patient or mechanical circulatory support, your pulmonary embolism thrombectomy procedure, or complications, because we have to account for those when they happen and be prepared. And I put here 2 of them that are recently being addressed, the massive hemoptysis that Chang and all discussed, advising for a protocol for massive hemoptysis, who does what and where and when, and even forming a massive hemoptysis kit, so have everything on board if you need to address that. And it's something that's very dear to me, and increased mortality by about 40%, the endovascular occlusion balloon for SVC tears on lead extractions. So any electrophysiologist doing a high-risk lead extractions will have that as a backup, part of the protocol, as a safe maneuver. Daily huddles or pre-procedure huddle. And that's important because when you start a day, you want to know what you're going into. One is the complex scheduled cases, but also the add-on emergencies, and how do they feature, how do you triage and prioritize them. And of course, you want to do them early in the day. Staffing, some of them require a different coverage ratio, so those should be discussed. Equipment, is the equipment running in the EP lab 1 or 2, or do we have to put everything on? And of course, prepare for potential complications. Where is the crash cart, where is the defibrillator, and so on. And we try to do this religiously, and most of the times works. Having checklists, more and more checklists have made their way into the healthcare. And sometimes sounds like a cliche, we have the timeout checklist, but having checklists for emergencies, having checklists for special procedures is important. And then it's improving care and safety in the non-operating room anesthesia, on a paper by Lutzman and all just published in August. Or Chung and Dudley advised and advocate for a timeout in a NORA location, especially interventional radiology, involving all the players, including the patient, because positioning and laterality is important. And somebody mentioned, I think Brian in the first talk, that wrong side procedure happens more often in NORA. So get a patient involved from the get-go and know exactly head first, feet first, lateral decubitus, and we're doing right or left lung biopsy. Having a director of NORA, I see more and more departments establishing a NORA division. And that's important because they are the glue between the moving parts. And they are the liaison between all the players and addressing present issues or formulate future goals. Now, I want to throw in here the team care model that's different for every institution. So we have residents who have a require NORA rotation, and yes, it's only 2 weeks, but it's there. or CRNAs, or a combination thereof. And it's important to work with those players, the residency program directors, CRNA leadership, to establish the goals. And I'm a strong proponent for forming core teams for each location, though might not be doable for every institution. What we do at Cornell, we have weekly for IR or monthly operations meetings for GI and EP, daily huddle for each suite, email chain for like few days ahead, scheduling complex patients, or same day message chain for the same day cases. Emergency contact number, somebody, Brian mentioned, do we know who to call if we have an emergency? Laminated big numbers at the front desk. Emergency checklist for equipment. Do we have the point of care? Do we know where it is? Is it plugged in? Are the cartridges expired? So we have a checklist for those, and also disseminated to everybody involving care on those suites. We have an emergency manual for each location, but it's also in Epic, so it's easily accessible. We have protocols for patients with LVAD and pulmonary hypertension. Simulation session, we're working on it to have it biannually, and we're also working on videotaping, because it's hard to get all the players on board to participate. We big departments, both for anesthesia and GI and IR, and it's hard to get everybody to those simulations, all the nurses and all the techs. So it's difficult on a 2-day per year to get everybody. So we're planning to videotape and disseminate that, and do it on a time when most of the people can attend. May it be the grand rounds for our department or for them. We also do combine QA conferences, M&M conferences. I had given grand rounds to the GI department, and we are planning to have common like conferences or journal club. It's important, and I cannot reinforce enough. I know Basim mentioned the robotic bronchoscopy, and just a quick aside that we are just purchasing in the next few months our robotic iOS for the bronchoscopy suite. And I found out, and Brian mentioned, you sometimes have to invite yourself. And I was told, well, it's the same footprint as navigation bronchoscopy. I said, well, you just have to move your machine few inches towards the wall. I'm like, okay, we need to know. So I insisted on a walkthrough with a rep and everybody involved, the bronchoscopist, the pulmonologist, and the nursing. And so that particular bronchoscopist called with the rep and said, please make sure you call Dr. Anka to be present at the walkthrough. And I'm chiming in, I'm like, I'm here. And it's true, it's similar, but some logistics still have to be addressed. So insist or invite yourself, as Brian mentioned. Don't be shy. And even more so for the new suite. We're remodeling the whole recovery area on AP and Cath Lab. It's like a 2-year project that hasn't started yet. But everything from AWSs or PICSs to, I even insisted, enough space for a chair for our colleagues. So we have to be part of discussions. We have to have a seat at the table and build relationships with our colleagues, because that's half the battle, being there. That's why I think having a NORA director and hopefully a core team if possible. I always say that NORA is a division of locations and not people. But I think there is some place in having a team that's more familiar with the location. ICU, as Basim mentioned, is becoming a new NORA location, so we have to acknowledge that. And institutional NORA committees, some places have it. Multidisciplinary projects, anywhere from simulation or present joint sessions at conferences, either anesthesia or IR or GI, or multi-institutional projects. So all those will help. And I will end saying what I say, as Brian and Basim before me alluded to, the numbers are increasing, and we have to have a seat at the table, communicate, collaborate with our colleagues. That's the only way to go. And the number of papers on NORA are increasing tremendously. Thank you very much.
Can you, thank
Thank you so much, Diana. So I think this is a really good segue into our next panel of speakers. We so often hear about anesthesia considerations for these locations, but what are some of the procedural concerns? So I'm really excited to present a panel of a gastroenterologist, a cardiologist, and an interventional radiologist for their concerns for these locations. So please come up, Michael Coachman, Thomas Farrell, and Sarah Guilano. Our first panelist is Thomas Farrell. He is an interventional radiologist at North Shore University Health System in Illinois. He's a fellow of the Society of Interventional Radiology and an examiner for the American Board of Radiology. Michael Coachman is the Wilmot Family Professor of Medicine and Surgery in the Gastroenterology Division at the University of Pennsylvania. He has served a number of administrative roles in his department, as well as leadership roles within national societies, and is the editor for Techniques and Innovation in Gastrointestinal Endoscopy. Sarah Guilano is an associate professor of medicine and associate vice chair of diversity, equity, and well-being for the Department of Internal Medicine at the University of Michigan. She's also the associate section chief of cardiology at the LTC Charles S. Kettles VA Ann Arbor Health System. So welcome, panelists. Thank you so much. So if we could get Dr. Coachman's slides up on the screen, and I think you'll take it away.
I'd like to thank Rich and Megan and Emily for this. What I'm going to do today is kind of take you through issues, provide absolutely no answers, and hopefully provide some provocative conversation and talking points. Really want to keep everybody happy and achieve a successful outcome. And clearly, thematically, it's going to blend with the first three speakers, and I suspect also with the next two, in that communication is critical. So specifically talking about GI endoscopy, pearls, the big issues we have to deal with are when to intubate, and there are clearly clear indications. There are also clear indications, and there are unclear indications. GU, I think we could all agree, gastric outlet obstruction, cardiopulmonary compromise, question for foreign body retrieval, and what is a prolonged procedure? And how do we sedate? Absolutely critical to understand that when we want anesthesia and we have anesthesia, it's not because we can simply do moderate sedation. It's really to get to a deeper level and to also provide additional backup because we already suspect that there's some complicating issue with that patient. Not that it's going to be a surprise to anybody in this room, and I already was referred to as UGG earlier today. Endoscopists are not uniform or predictable. We all have different endoscopic skill sets. We have different approaches. We also have different communication skills. We also may or may not have trainees, and we may or may not be doing diagnostic or potentially therapeutic or potentially endosurgical procedures, which are all going to have different complicating issues. Surprise, anesthesiologists are also not uniform or predictable. They have different skill sets, different approaches, and clearly different communication skills. Everybody here is on the upper end of that bell curve, but there are also people who balance out that bell curve. Procedures, even though we may say it's a standard diagnostic EGD, or we may say this is an ERCP for choledochal lithiasis, they're not all the same. We may or may not have regular trainees who may be first, second, or third year fellows. We may have advanced trainees, and you also may have to deal with a new faculty member who may be first day July 1st. No one ever here has experienced that, and they get the yips. So for those of you who play golf, you watch them with yips. Patients, clearly not uniform or predictable. But one of the things that I think is a truism across almost all of the procedural areas, and again, this is thematically building on what was said earlier today, that the sicker the patient, the more likely we are to perform the procedure. We're replacing often surgical procedures that are absolutely going to be mortal for the patient, and we are attempting to avoid surgical procedures, and especially when in GI we're performing what we refer to as organ-sparing procedures. They may be 4 or 5 hour endoscopic submucosal dissection of an early gastric cancer or an early colon cancer. And the sicker the patient, the more likely we're going to deviate from the plan that we told you about before the procedure started. So multiple variables, we don't need to get into those right now, but there are the key ones really going down to the fellows, the attendings, anticoagulation, which I refer to as the drugs of the devil, which are provided by the cardiologist. And then I specifically will call out cardiology, as you guys probably do also. LVADs are the devices of the devil. And of course, when we're doing an LVAD patient, it's because they're back for the 23rd time for that GI bleeding episode, which we know is never going to go away because they have continuous perfusion. And also, my personal favorite, which we can talk about, is the pre-LVAD, pre-transplant evaluation for the person who's had congestive heart failure for 20 years, who now is in the hospital on a milrinone drip, and then is brought down for us to do a procedure. What are the things that we're concerned about? Successful completion. I think we all are concerned about that. No question about that. We want to get that intended objective done, and we will also have to deal with whatever other issues arise. We want safe completion, not just simply successful, but safe completion. Stable field, again, things that you've already brought up, that's going to be procedure dependent. Certain procedures, movement is not really a big issue, and respiratory and cardiac we should always anticipate because we're not going to have cardioplegia for our procedures. And we need, because of the NORA applications, we have limited room resources, so it's not that we are pushing, it's just a question of how do we accommodate what are really institutional constraints on our practice. We have X number of cases we have to get done in a day. Do we want to do them at midnight, or do we want to get them done by 5 p.m. if we can? And patient satisfaction, again, going back to safe and successful completion, but lack of recall. We may be taking out big things, which is the intent of the procedure, and then we may have, little incidents may occur along the way that we all need to accommodate for and be able to handle. Things to remember, we can do moderate sedation. You're there for other reasons. And we have to really look at what are those goals of the sedation and the reason for anesthesia support. So conversation is absolutely critical. The problem with conversation in a lot of areas, if it's at all similar to the environment that I operate in, is that on the outpatient side, we have roughly 8 rooms running in our NORA environment there. We have 2 anesthesiologists. We have 7 to 8 CRNAs. And there are lunch breaks, there are room switches, there are flips, so you may talk to who you think is going to be responsible for your patient. You find out it's not. On our inpatient side, even though we're talking about NORA, we are essentially NORA because we were left behind in the old hospital along with bronchoscopy when everyone moved to the new hospital. So what happens then is we have 2 hepatology teams with 2 hepatology attendings, 2 luminal GI teams with 2 attendings, and then therapeutic attending, 1 in the morning, 1 in the afternoon. So there's 6 attendings. There are going to be anywhere between 1 to 2 anesthesia attendings and usually 2 CRNAs, and God forbid, an anesthesia resident in this environment. Level of consciousness and cooperation, absolutely critical. Cardiopulmonary status, usually, especially for our inpatients in the NORA environment, they are ill. And then also clear conversation about whether or not we anticipate intraprocedural, post-procedural pain when we are doing, for example, in or outpatient drainages of pancreatic necrosis. There may be some pain with that. When we're doing esophageal dilations, there may be pain. And prolonged procedure is clearly an issue with hypercarbia. Obviously, kinetics change. And anesthesiologists are well aware of it. Gastroenterologists, not so much, that VTE is a real issue. There is no question that there have been adverse events related to prolonged endoscopic procedures in the absence of VTE, prophylaxis. Anticipating the length of the procedure is a clear part of the conversation, indications, the goal, discussion of the operator's skills and the plan, not simply just with our techs and our trainees, but also with the anesthesia team is critical. And then a conversation as to whether or not there will be an airway provided or not. I have a default, which is if I want an airway, there will be an airway. If the anesthesiologist wants an airway, I never argue about it. That's not what a lot of my colleagues do. They will say, well, this is going to be quick, I really don't want an airway. But my feeling is if an anesthesiologist or CRNA wants an airway, it's your airway. It's not mine. If I'm down in that airway, it's what I call a bad day. No, that wasn't that funny, I guess, okay. But I can help you find it if you need it in an emergency. And clearly anticipating those issues are very clear. The BMIs of the average American, as you know, are pretty high. 99 is pretty clear, but as that first case illustrated, what do you do with that outpatient who's got a BMI of 41, 42, 43, has OSA? Do you have them bring in their CPAP? Do you give it to them intra-procedure? Do you give it to them post-procedure? How do you recover them? All issues that need to be dealt with. I'll stop there. I don't have a summary slide because this was raising issues for discussion. Thank you for your time.
Go next.
Whoa, put this even there. Morning. My name is Tony Farrell. I'd like to thank the organizers for inviting me. 2 years ago, I participated in the ASA online seminar. It was educational. Thanks for inviting me back. I am an interventional radiologist. Yes, I'm not your least favorite, maybe your second least favorite person to be here, but that's okay. I feel the love. I work in Evanston, North Shore. I'd like to pay tribute just briefly to two guys, Jeff Ender, Joe Sokol, two former chairmen with whom I've worked on and off for the last 20-something years. They have promoted and enforced a culture of safety, and in no small way, I think a lot of my current practice and our current high standards are due to them. They're here, and I'll say hi to them later, but Jeff and Joe, you've made me a much better interventionalist, much better physician, and I think in no small way have contributed to patient care at the Great North Shore. Enough about me. Two topics for discussion, and both you've probably already heard about. One is communication, one is standards of practice. With regard to communication, let me go back one here. So for the physicians in the room, we all went to medical school, and after medical school graduated, went to various specialties. For the anesthesiologists in the room, we learned the language, partial pressures, fat solubility, volumes, monitoring, scores. You guys have a lot of scores. That's good. I'm a radiologist, more worried about feasibility, technical success, clinical success. Can they get this 38 thousandths of a guide wire through a 5 French catheter? That's kind of my focus. So when we come together, when we kind of deal with patients collectively, I think communication is kind of key. So we learn to speak your language. You try to speak our language. That's good. But I think communication is key. And I think I look at the improvements in patient care as it relates to NORA and moderate conscious sedation at my institution over the last 15, 20 years. And it's, communication is kind of key. We have to be on the same page all of the time. I'm an interventional radiologist, so one of the procedures I do a lot of are vertebroplasties. So these are essentially the injection of bone cement into osteoporotic compression fractures. The vast majority of patients are old and osteoporotic. Most patients are female. So this is a kind of a recollection of the last 600-odd patients we did by age. And yes, there is someone there she's 103, We did it under conscious sedation. She got off the table. We did fine. But this is my world, so maybe just for 5 minutes, kind of walk a mile in my shoes. So this is my kind of daily bread, shall we say. So I have a patient in their 80s, comorbidities, you name it, heart failure, COPD, AFib, and then we're going to put them prone, and then we're going to give them sedation. And yes, we're going to do it not in the OR, not in your natural habitat, but in our natural habitat, in interventional radiology. So the vast majority of these patients, well, I've done under conscious sedation. But there's a small percentage, maybe 5-6%, we have approached anesthesiology with a view to doing MAC. And again, it's your show. If you decide to intubate, that's your decision. If you want to give Versed and Fent, like we would have given, fully understandable. If you want to give propofol, again, your decision. But again, so this is, I don't get to choose these patients get to choose me. I can't say, no, we're not doing this. Otherwise, you're basically committing these patients, who are mostly elderly, to 6-8 weeks in bed. They become even more decompensated, lose their muscle mass, become more osteoporotic, they get DVT, they get pressure sores, and it's just not a good outcome. So yes, for radioplasty, I'm the cement guy, and again, no small ways have been benefits of working with the best, Jeff and Joe and his team at North Shore in the last 20 years, that we've kind of managed to have an excellent track record with these patients. This is my solar system in some respects with regard to sedation dosage. It's pretty small. I think you're looking at this. So size of the sphere corresponds to the number of patients that would get the dose. So the most common dose there is 1 of 50, 1 of Versed and 50 of fentanyl. I'm sure it's kind of a much smaller dose than my colleagues in GI would laugh. I'm sure you're laughing at this. I mean, what can you get for 1 of 50 these days? Not much, not much.
A rectal exam.
All right. Well said. So this is this is my experience or our experience with conscious sedation in a predominantly elderly patient population. Again, thanks to Jeff and Joe, we have high standards, we enforce them, we get the job done, minimal complications. Second item for discussion is standards of practice. I'll just quote one publication here. It came out 5 years ago in the European IR literature. Essentially, they did an online survey of interventional radiologists in Europe. And the questionnaire involved what techniques to use for monitoring patients. So the usual suspects are up there, pulse oximetry, ECG, and blood pressure, all 90%. The outlier, sadly, was monitoring event-tidal CO2. So this is, this is 2022. This should not be an issue. And again, I think, we look to you all to come up with standards and enforce the standards. But ultimately, I think a lot of times the ball is in our court. And I think this is 2022. End-tidal CO2 monitoring should not be an issue. It should not be a kind of a question mark or an asterisk or something to be discussed or described at a later point. They are my all too few slides, but again, topics for discussion, and again, thank you for your time.
So I kind of wanted to keep it informal. I'm just joking. I'm very sarcastic. So I just wanted to keep it a little bit informal and ask the audience, how many of you guys staff cardiac rooms, like especially interventional cardiology rooms? This is kind of helpful. Okay, great. So the way I think about NORA in the cardiology, and I'm kind of thinking about it more from the interventional cardiology space. We typically use it in 2 different buckets. A lot of it tends to be our structural heart interventions, which I'll kind of touch base on in a second. And then also, kind of like GI, as surgeons have kind of deferred complicated patients, more and more we're getting these patients to revascularize in high-risk coronary interventions, frequently with the support of complex hemodynamic support devices. So, in the structural space, TAVR is really the mainstay. There's tons of TAVR sites across the country. I think it's like over 600, probably approaching 900 sites. So you probably are at an institution that does transcatheter aortic valve replacement. We really rely, at least at our institution still, on our anesthesia colleagues to be a part of the procedure, especially as TAVR has kind of expanded into lower risk patients. You know, my job is to provide as good as, if not better, of a aortic valve replacement outcome as a surgeon. And so if I run into complications and don't have my anesthesia colleagues there with me to kind of manage those complications, I think I'm not doing the patient a service. As many of you may know, with TAVR, as the valve is being implanted, depending on the particular type of device, you know, there's a couple of kind of crucial moments there where it feels like you're jumping out of a plane, you hope your parachute opens, and frequently have quite a significant amount of hemodynamic or rhythm kind of changes that time, and we really can rely on our anesthesia colleagues at that point to help support the patient. Other structural heart interventions, which are slightly less commonly performed, but I think will be seen in an increasing capacity as the technology is improved, are interventions on the mitral and tricuspid valve. Mitral valve a little bit more ahead than the tricuspid valve technology at this point. But for the vast majority of these cases, you know, we really rely on anesthesia to support the patient with generally general anesthesia because of the prolonged duration of the case, but more importantly, our reliance on transesophageal echo to perform these procedures. It's almost gotten to the point now where we use fluoroscopy less than TEE, which is, you know, also good for the anesthesiologist in that there's less radiation exposure that you'll have during that procedure. But I think if I made slides today about these procedures in a year, they'd be obsolete, as the technology for intracardiac echo has really become pretty advanced and really near TEE quality. And so it could be that in a couple of years, the need for anesthesia involved with these procedures may change, and perhaps more focused on hemodynamic support and possible complication management rather than the need for persistent TEE for these procedures. The other bucket, like I mentioned, are kind of these high-risk coronary interventions. You know, we've gotten pretty aggressive with some of the types of procedures that we can do in the cath lab to try to revascularize patients. Frequently, this is done with patients when their ejection fraction is low and cardiac output low, with devices such as the Impella, or less commonly used tandem heart, to help support the patient. But even in those settings, you know, we may have issues with patient comfort on the table, patients with high BMI, you know, and just laying still for 4 hours to open up several chronically occluded arteries is just not possible for the patient. So we really rely on you guys to help us with that situation. But also, unfortunately, some of them may suffer hemodynamic collapse, and then having an extra pair of hands there to help manage the hemodynamics of the patient while we're focusing on the actual catheter kind of treatment to try to reverse the issue is really helpful. And I think, and I was really interested in almost asking you all the question and hearing about when we run into problems in the cath lab, say it's in a case like a STEMI that I have 2 o'clock in the morning. It's just me and my team. And unfortunately, some of them can get quite ill. And, you know, I think there's so much intra-hospital and different hospital system variation of who comes to codes in the middle of the night in the cath lab. There's like an airway team frequently, but how do we kind of work together with our anesthesia team to potentially provide more backup in these critical situations where, you know, I think as interventional cardiologists, we're getting so used to having the anesthesia team there to help us with these complex cases. You know, how can we kind of acquire similar type of support in a like emergent situation like that where there's just fewer staff after hours? So, but I'm never going to get rid of my heparin. I will try to get rid of the LVADs though, if I can. So, all right, thanks so much.
Perspectives is really, really helpful in kind of setting the stage for our discussion for the next part of this conference. I wanted to ask the panelists of our proceduralists, what if each of you could elaborate on what are the most common misunderstandings about your practice or about your procedures that you have encountered when working with an anesthesia team, or that you would like addressed or dispelled in this meeting? Is the mic on?
Can you hear me?
I think you should be.
Can you hear me now? No, it isn't.
I think
Oh,
you should
now
be
it's
good.
on?
There
All
you
right.
go.
I think for me, it's we try with a lot of these structural interventions and even the complex coronary interventions to plan ahead and really follow the pathways that you all have talked about with intense procedure planning. We loop in our anesthesia colleagues the day before with all the case information on some of these complex structural interventions, and always do at least usually 2 timeouts before we actually start the procedure. But I think the biggest misunderstanding for me is kind of that latter scenario that I talked about, where we feel like we have needs from a not only intubation standpoint, but potentially hemodynamic support for cases that maybe started out relatively straightforward, but we dissected the LAD with some atherectomy procedure, or the patient just became unstable for other reasons that might not even have been cardiac in nature. And so how do we kind of work together to try to figure out how to best take care of the patient? And I think our misunderstanding is like there's a group of anesthesiologists just hanging out, like ready to come, save our butts in the cath lab, which I know is not the case. But I think also maybe on the flip side, I certainly have encountered some anesthesiologists who are like, why didn't you call me sooner? It's like, this happens really fast, So, but I think to me that would be the biggest challenge.
So it's not just about the airway, it's also about hemodynamics.
Hemodynamics, yeah,
Yeah.
almost always.
I'd say from an IR perspective, there's kind of a misunderstanding of how sick sometimes our patients are in IR. We have a saying in our place, when they get too sick for the ICU, send them to IR. And it's, so we have this, if there's an ASA 6, I think we would be there. Some of these patients are, multiple organ failure, bleeding from every orifice, and it's just like, call IR. It's just like, we're like the cavalry. It's just like, we've given everything else. We're on our 20th unit of blood, 6 of cryo, whatever, call IR. So you're stuck again, 2 in the morning, and, it's like you're an army of one. You got your tech, you got your nurse, you get this patient who's just crashing and burning in IR, and then thankfully anesthesia show up, and they're like, there's this kind of wake, this kind of Revlon moment. It's like, oh my God, what's going on here? This patient really is sick. And it's like, again, we don't get to choose our patients. I wish we did, but just truly how sick some of our patients are, and how grateful we are that you show up at 2 in the morning and the difference you make. Thanks.
So I'll take it a little different direction and say that we don't have any procedures other than ICU procedures that are not attended by either CRNA or an anesthesia attending. So I would say that the big issue for me is really still a communication issue, which is that, for example, and I'm not at Penn, I'm at Penn, but I'll say I'm not at Penn, that our outpatients, the anesthesia attendings who work with us, are a relatively tight cohort, and will review those charts the day before and already have their anesthesia plans prepared, already be aware of the patients that come with an airway and the ones that come with another airway. Meaning I have a lot of patients who are head and neck cancer patients that may or may not be trached, have stenosis, et cetera, so they already have their plan set up for those patients. On the inpatient side, it's a bit different, and I think it's a reflection more of academic institutions that those patients may or may not be prepped or reviewed by a resident the day before, but the anesthesiology attending and the CRNA may not actually meet that patient or review that chart until that morning. And then it becomes additional equipment that may or may not be brought to a non-OR site or wish to be in the room, or an A-line, et cetera. And that adds complexity, confusion to the patient. The second issue I'd say is understand the duration of the procedure. So do we want a rapid onset? Do we want a slow onset? Understand where those pain points are during the procedure, and then understand when we need it off. I think you've all seen it, we've seen it. We are doing a painful procedure, we say, okay, we're done, and the patient is still maximally sedated, and then all of a sudden it's, all right, let's bag them. And the answer is to make sure everybody understands and communicates that we're reaching the end so you can start to get them light and wake them up, which really I think helps everybody and takes the drama out. As I say at the end of the day, no drama, it was a great day.
Awesome, thank you. So what I heard you say was preoperative planning and understanding the progress of the procedure.
Absolutely.
Awesome. All right, thank you so much for your perspectives. I'd like to open it up now to the audience if they have any questions. I think we have Rich Ehrman and Dr. Cole. He will be roaming around with mobile microphones. So I see a couple of questions over here. And then we also have a virtual audience as well. For the virtual audience, if you could please put your questions in the chat, and Dr. Lane Fall will help us address those questions.
Thank you, everybody. Just a question. I think one of the things as an anesthesiologist that I always have a hard time grappling with is the preoperative evaluation. A lot of times there are two specialists involved. There's a proceduralist like yourselves and an anesthesia professional. Neither one of us typically is always responsible for a before time pre-op evaluation. And so I think a lot of times these patients show up, even on an outpatient basis, with a lack of appropriate evaluation preoperatively. And then we end up doing the preoperative evaluation and either delaying the case or even potentially canceling the case. So in your experience, and maybe this is throughout the entire system, I know there are folks that have preoperative clinics through anesthesia. Not all institutions have that. What ways in which have you seen it be most successful that people come with appropriate evaluations so that we can do the cases safely and successfully?
I guess I'll take a stab at that. So I have a very stilted practice in that I'm straight referral from other gastroenterologists or surgeons. So my patients have already likely had some sort of anesthetic before, so I have a pretty good idea. Having said that, we have Epic, we can argue about Epic all we want and Care Everywhere, et cetera, but all these patients that are scheduled, it is our obligation, we're supposed to put our orders in ahead of time, review those cases, and we should be able to flag and route that chart. We have designated NORA outpatient attending who's in charge, and we just route those cases to him for review, and he will either say, okay, I see what needs to be done, I'll communicate to the attending who's going to be there, or you know what, we need to see the patient first. So we have, again, it's about communication and review and pre-procedure planning. So we take it upon ourselves, and we really, if someone gets canceled that day, we really kind of feel it's more our fault than it is the anesthesiologist's fault, except when they come in on those diabetes meds. Which ones again?
Oh, sorry. Oh, I was going to echo that. I mean, I think we're pretty good at predicting most of the kind of intra-procedural anesthesia challenges. I think every once in a while we have questions about airway, for example. I do most of my TAVRs at the VA hospital right now, and I know that when there's a question, there's an anesthesiologist that I can call, typically in the PACU, even if it's not an anesthesiologist who's going to be directly involved with the case, but they can come up and give me a great assessment of any kind of airway challenges that might sway either TAVR versus open surgical aortic valve replacement or just management at the day of the procedure. So I think having a point person for us is key.
Yeah, so if you fail to plan, you plan to fail. And we're working towards an outpatient model where we see most of our patients in advance, history, physical. So on the day of the procedure, there are no surprises. That requires resources, it requires space, it requires manpower, and a seismic shift on part of our administration. But yeah, bad news we can handle, but surprises we really don't like. So we're looking at the outpatient model to see those patients in advance.
Thank you. That's a great question. We do happen to have a pre-admission testing. However, those complex patients that you mentioned, either as outpatient or inpatient, oftentimes it's initiated by our GI colleagues, for example, in GI. And then if they heart failure, we have a multidisciplinary email chain with the heart failure, cardiac attending, GI attending, the anesthesia team, usually myself or the person scheduled for the case, and the GI fellows, because they're the common denominator. And then we agree upon a plan and maybe say, okay, we'll schedule this once they get optimized and so on. For the same day, we huddle in the morning and address those. And honestly, developing a relationship with your colleagues, like sometimes they'll text me, the GI attending, hey, I have this guy coming down the pipe, what do you think? Let's preliminary discuss and then how we plan. So I think it's crucial to have your relationship with your colleagues.
Thank you. Keep it for now. You have another question? Jeff?
Yes. So, Emily, I just want to quickly interject. We don't really have a spot up there for Brian Thomas, but if the audience has questions for him, we'll freely take those questions also.
Thanks, everybody, for sharing so many insights and expertise. I wanted to raise a point for the conversation around productivity pressure that typically exists in most of these locations, which personally I view as probably the biggest enemy to patient safety right now. I think the most common model is the notion that when the procedure room is not occupied by a patient with a team actively working, we're wasting time. And that white space, so to speak, in between the procedures, I don't know that we have a culture of discipline about how we use that for patient safety purposes. The huddle has maybe made a little bit of inroads, but my experience is the teams all sort of scatter between cases, and we don't really take that moment to say, maybe we need to get a little bit more discussion around the patient. So do we do one less case a day and use that time a little bit more effectively for patient safety? It's not a popular conversation, but I think production pressure and productivity are a big issue right now.
So I made an oblique comment about administrative issues, and I think that's really a critical thing from the health systems, because how are we measuring the productivity? Is the productivity per RVU per physician? Is it per procedure per physician? Is it per room? And one of the critical issues is the on-stage, off-stage. Look at basic operations training, that we don't necessarily go linear in these rooms. If we're going linear, we're doomed to fail. And it requires the administration to recognize that the individual room productivity may suffer, but they have to properly resource to be able to accommodate those patients. And if it requires 1.5 or 2 rooms per proceduralist or operating physician, that's what they have to start to look at. And if that means hiring more anesthesiologists, CRNAs, et cetera, they need to resource up to be able to do that. So I'm not pushing back on the productivity issue, the RVUs, the speed. It's a question of how do we measure what that should be, and how do we get the resources for it.
Any comments? Bassem?
One of the things about productivity is to look at the potentials for delays or prolongation of time of the case. For example, if you have a patient that you anticipate some airway difficulty and then you proceed with sedation without an airway. If you get to difficulty that managing that airway or managing that complication will take a long time, as well as documentation for the event, not to mention the suffering that this patient will go through and all that. So one of the things to do is to have the proper planning up front. If you think you're going to need an airway, let's put an airway in and let's proceed with the case. It is not going to take much longer, maybe a minute or so, but that's going to save time at the long run. Also, case cancellation is a huge issue in productivity. And one thing that the question was how to do pre-op evaluation, and that's impossible. Different systems have different ways of doing that. Some people have pre-op clinic and they can see all patients. That's actually unheard of in all areas, but they see some select patients. But also there are some online systems where you can allow the patients to access that and answer questions for themselves. And red flags are raised when there are certain boxes are checked, and those are the ones who would benefit from pre-op evaluation, or at least a phone call or email between the clinicians involved. and address those issues beforehand and avoid the cancellation of the day off. That's a huge, huge predicament to the productivity, case cancellation, empty slots in the schedule, if you will. So those are things can help productivity and make it better, but I agree with you that we should not push or rush things just for the sake of productivity. We should give its case and every patient their due time and their due attention. But there are certain things that we can do, and the day huddles, as Diana mentioned, are very, very effective in addressing issues, just even to anticipate equipment needs and prepare those ahead of time. So avoid equipment delay from procedures end as well as anesthesiologists end. So here are a couple of thoughts that could help with productivity issue. Thank you.
We have a question from the middle of the room, Patty Riley.
Sorry, my mistake for standing in the corner. We've gotten better at building NORA rooms larger and accommodating anesthesia equipment. The biggest frustration I see right now has to do with the electronic environment. The monitors don't link to our record, the record doesn't link, you can't get to the anesthesia record, the main OR can't see what's going on in the NORA suites. So for the builders, and planners, how do we design the electronic environment to facilitate anesthesia for NORA cases? And a question for Brian, how big is documentation a factor in the malpractice cases you've seen? So the inability to keep a good anesthesia record the way we would in the OR. Thank you.
Sure. One thing is, as you build those areas, is to use the same electronic system being used in operating room, whatever anesthesia record system you're using. The same, try to use the IT to get the same wiring into those new areas, which we have done and worked out well. The challenge we have is the third-party vendors that some of the procedures use. I can mention names now because I'm not connected to any of them, like Provations and others, and Census and Cardiology and Siemens and all those. That's when those do not communicate with your anesthesia system, and that would require an interface, which is a huge undertaking by the IT department, but can be done. So from an anesthesia standpoint, it's much easier to have the same system, same platform for all those locations, but we need help working with our interventionist colleagues as well as our IT department to build an interface between their systems and ours so as their documentation can get into it, and this way we can have a whole record for the event. And not only apply for just NORA services, as I mentioned, the anesthesiology services, but also for procedural sedation services and documentations, which we have oversight over, and would help us tremendously in monitoring quality centrally for the health system. This way we can link the procedure with the events and the sedation record, and we can identify issues and help the procedures to provide a safer care. Back to you.
Thank you. And I think, Brian, do you want to address that question about documentation and
Documentation, of course, is always a central part of litigation, whether it's electronic or in the older days, paper records. From our perspective, our advice to our anesthesia professionals who we insure is treat the patient and don't worry about the record until we've taken care of the patient. We can overcome artifacts or lack of documentation in most cases, not always, but most of our cases do not turn on documentation. It's the other evidence that I alluded to in some of the more egregious cases where there's testimony from other providers on the OR team, or there's other evidence like metadata and other things that will undermine the defense. If our insureds, our anesthesia professionals, are paying attention and vigilant, and even if there is a lapse in the records, we have other evidence that we can utilize, including their own testimony, their custom and practice, things that can fill in those blanks. So it's not critical in our experience as much as it might be perceived by the healthcare providers.
Great, thank you. I think we have a question here.
So, Patty, and then you.
Hi, thanks. A question for the proceduralist. Do you see the trend moving more away from you doing your own sedation? That would be number one. Your colleagues as well, have you heard discussion around that moving more to NORA and using anesthesia professionals? And my last question would be around your societies. Do your societies talk about what's all happening around the anesthesia practice and NORA and what you're doing, your procedures?
So in reverse order, my colleagues and I greatly appreciate, and that's an understatement, your availability collectively. Going back to the Jeff and Joe show for the last 21 years, they have never said no to me. Anytime we go to them for MAC anesthesia, general anesthesia, sure there's a conversation, and sure there's back and forth, and sure there's a discussion, but they have never said no to them. So we are grateful, and we continue to be grateful. And yes, NORA is here to stay. Go back to your first question regarding administration. If I get the question right, is administration of meds other than Versed and fentanyl. I know there's a trend in amongst European, I think particularly the German and Austrian gastroenterologists, to give or to be able to give propofol, etomidate, and so on. That may be the trend over there, and maybe more of a manpower issue. I don't know the exact details. Where I work, then in Hell's Half Acre, where I work, we're quite happy to give Versed and Fent. We're quite happy for you folks to do propofol, general anesthesia. We have no interest in crossing that line. We want to focus on. I want to focus on being able to get a 13 gauge needle through a 5 millimeter pedicle T5 on a 95-year-old with osteoporosis who's prone, et cetera, and yes, get her off the table in 15 minutes. That's my focus. So my colleagues and I, we certainly have no interest in crossing the Versed and Fent line. And again, as I said before, anytime we've approached our colleagues in anesthesia with regard to MAC, some of them end up giving just Versed and fentanyl, which is what we'd have done. But we're so much happier. They get to monitor the patient. We get to do the procedure.
Yeah, I think we're only going in the cath lab only going to be utilizing anesthesia services more, both as the procedures themselves expand. But honestly, I think once you have a taste of how nice it is to have someone assist you with the sedation, that then you realize, well, I really should have been doing this more. And I think in particular of our very large BMI patients, I'm desensitized now. BMI is less than 40, really no big deal. 45, that's kind of getting high. I did a coronary angiogram on a young lady whose BMI was 65 last week. So somebody like that, having your services there to help keep her comfortable in a very safe way when she's in a kind of awkward position getting radial access, I think is key. It's interesting because in our hospital, there's been increasing use of propofol in the ICU, and how that translates when patients come down to the cath lab or EP lab for administration of propofol during a procedure. We're not titrating it in the same way that anesthesia might, but this is like their mainstay of sedation for the patient. So we've run into some kind of roadblocks of who's monitoring the patient, who's administering that medication. Can the cath lab nurses administer propofol? So I think there may be, at least in my own, at the University of Michigan, there may need to be some clarification on that standpoint. And from a larger society standpoint, certainly we talk quite a lot about cardiac anesthesia backup and assistance at our society meetings, but not in the same language as you all do. And honestly, it's been really great just hearing kind of what the early presentations have been and thinking about it from a different perspective. And so I think just like we've learned how to do timeouts together, I think learning how to kind of talk about the anesthesia administration in a similar way would be really, really helpful.
So from a society perspective, yes, active conversation. There are a number of articles very clearly showing the proliferation of propofol and anesthesia services in the U.S., starting really in the metro areas and then diffusion out. And part of the issues surrounding that are really the expectations in AECs. If we really look at historically where that started, it was really at the AEC level, where it was no question a production and turnaround issue because they recognized very quickly that employed anesthesiologists as a profit center. They're able to replace the RN in that AEC. They're able to go ahead and do maybe 1 to 2 additional colonoscopies per hour in that AEC, and then really beyond, somewhere, depending upon the AEC, 9 to 10 procedures per room per day. Everything becomes sheer profit. So that's really where that started. In the major academic centers and in the hospitals, it became then the expectation that patients who had outpatient propofol, the procedures are now painless. This is part of the epidemic in the US. Painless and perfect. Everything should be also free. So what happens is you're competing against yourself and you're competing against your colleagues just to even provide the care. Forget about the quality metrics of the outcome of the procedure. The patients, if you say, oh, we're not using propofol, boom, my friend had propofol, bye, I'm not having it done there. The issue in the, historically, I guess I may be the oldest one up here, so I trained back in the days of, God, fiber optics, no video and giving Valium. So do I miss dealing with the cords in the veins after Valium? Absolutely not. And then we looked at actually failed procedures. We had a 20% conversion rate of therapeutic procedures that were failed due to inability to sedate, not to complete the procedure, but just to sedate. So there's no question that proliferation has occurred in a very valid and necessary way.
We have a question here.
Thank you, everyone, for a very thought-provoking session. I just want to expand on the concept of NORA as we think about it. It's not just the procedural room, but also the pre-op area and the post-op area, and how you staff that, how you monitor those areas, and what is the level or the quality of staffing you have over there has a huge impact of what happens in the OR or that NORA location, especially because of the production pressures that we were talking about. So this is something that we do need to consider and talk about. What kind of nursing do you have in the pre-op area and the post-op area? If you're getting to start every second IV in the pre-op area, or your post-op nursing can't administer fentanyl and you have to go and do that all the time, it puts a huge amount of burden on the individual. So we should expand our concept of NORA to include the challenges in the pre-op and the post-op locations too.
I have the microphone, so I'm going to answer that, and then I'll pass it on. That's actually a great question, and from our institution perspective, EP and IR share the holding and recovery area, and the nurses have the ability, they start AIVs and they also recover. GI, we take the patients to recovery room. We're trying to standardize so everybody is trained to use point of care, everybody is trained to be able to discharge patients, it took a little effort and time to get everybody on board, nursing leadership to get that. We also revamping and remodeling our holding recovery area for cath lab and EP, and we have a seat at the table to redesigning the whole area. So you're absolutely right, that has to be addressed, and I think it's a slow progress on that.
Yeah, just a couple comments. I think that in the post-procedure recovery, the standard of care really needs to be the ability to recover general anesthesia patients, and that involves education. The other thing that I have noticed over time in this space is that we don't have the same sort of safety protocols in all of the NORA areas that have worked so well for us in the operating rooms. And so the propensity to take the wrong patient into the wrong room in a highly populated, high turnover GI lab, for example, is much greater than it is in an operating room. And so having mechanisms in place to make sure that we are taking the right patient when we're moving patients around between rooms and things like that really is a setup for concern.
Thank you. I'll focus that's a great question, by the way. I'll focus my comments on the post-operative care. One of the things we encourage folks to do is that whenever you build a NORA area, please make sure that you have recovery space dedicated in that area as well. By definition, these locations are away from the operating room. It is not appropriate to transport these patients through hallways and elevators back to the main recovery room, which could be very crowded and busy already and may contribute to delays in ORs and as well as in those NORA locations. So it's important to identify an area where you can build a recovery suite there and train the nurses there. What we have done is that we have provided opportunity for the nurses in NORA areas to train with our main PACU to see how they can recover patients and get some experience there. Most of the time, it's actually phase 2 in NORA locations, not necessarily phase 1. But once there's a lot of fear when they tell them that you might recover, somebody just had general anesthesia. But once they see that the recovery is much easier than recovering patients who receive procedural sedation, their anxiety levels goes down. The other thing that there's lots of meth out there in post-op PACU areas where patients need to spend a specific amount of time after sedation or after general anesthesia and so forth, and that is not true. It's criteria-based, and once we are able to educate and disseminate that information, that helps tremendously in the efficiency and turnover in PACU and allow for a space for the next patient to get out there. If you're interested, we have posted the criteria in our latest article looking at the oversight for procedural sedation. It's one of the appendices, and we use that score where if the patient meets the score, so the orders is discharged when ready. When the patient meets that score, they get discharged automatically. If there's any issue, they call the proceduralist or the anesthesiologist to assess and make assessment of whether the patient should be discharged or not. So these are important issues. One more question, but regarding the recovery, the backup. I heard this backup many times today. There is a misconception there that the anesthesia team is available anytime the procedures feel like they need them, they can call them and they're going to come and help them. Well, all the anesthesia professionals are phenomenal people, good-hearted. If they are available, they will come in a heartbeat and they will rescue that patient. But I always try to impress the procedure that, unfortunately, that is not available all the time. We're also pressed for productivity, and also there is manpower shortage everywhere. So there is not a team sitting there doing nothing, waiting for calls from different areas to go rescue, unfortunately. However, if they are available between cases or they can spare themselves from what they're doing, they come and help. But that should not be the base or should not be the expectations. So as we empower and educate and teach our proceduralists to be able to provide safe procedural sedation, and we're able to do that for about 100,000 cases a year, we also educate and teach on what is an appropriate patient selection criteria for a patient to be done under procedural sedation without the assistance of anesthesia care team. So in that case, we ask the proceduralists to only accept patients who they can provide safe procedural sedation for. And if they believe that this is not possible or there is a potential for issues, then they should consult with the anesthesiology department earlier on so as they can schedule them when there is mutual convenience for both. That would decrease inefficiencies, decrease cancellation, improve efficiencies, improve productivity, and also improve safety. So these are things that we need to keep in mind as we schedule those cases. Back to you. Thank you for the opportunity.
So, Emily,
Yes.
I do want to honor our break. We're coming up on the break, but we have 5 people lined up. Let's try and get through 2 or 3 of them before the break, and then you can ask the questions to the panel individually. We have 1, 2, and 3. Those are the first 3 kind of in the queue.
Did we want to answer any virtual questions at all?
There are none so far.
Okay. All right, sounds good.
Thank you all for the conversation. I practice in a large academic center, and I have the privilege of working in EP and IR and GI. And as a CRNA, I noticed that there happens to be some unit-specific practices among these different NORA locations. An example that comes to mind is in one off-site location, if they receive a total dose of a certain medication, then they shouldn't go to that specific recovery area, but the main recovery area. And that's just one example of a nuance among the different offsites. And I'm wondering, to improve patient safety, is the goal to standardize practice among all these NORA locations, or to create very insular anesthesia groups that are very familiar with the specific nuances of the practice environment, or is it somewhere in between?
And I have the microphone, so that would be ideal, and we're all trying to have at least a core team of people more familiar with that particular location. It's difficult because of the call coverage. So what happens at 5 o'clock when somebody else takes over, if they're not familiar, that goes for the whole team care model, residents, CRNAs, and attendings. In our EP lab, we have an ERAS protocol for catheter ablations that's been disseminated to the department. So provides some guidance, and I also put together a document, anesthesia for EP procedures, like a quick practical guide for whoever goes there not so frequently. But would it be a great idea just to try to standardize? I think we're running into the danger of telling people how to practice, and it's, I guess, difficult. And every place has their own different particularities. I don't know if you guys have.
I totally agree with you. The different areas have different needs, different patients have different needs, different procedures have different needs as well. So standardizing the practice is would be a myth, would be something, would be chasing a false belief that we can achieve that. But I would say more education, more training, and telling people what are the specific concerns and what are the specific needs for every procedure and every patient, and allow folks to kind of do their own thing and provide the safest care they believe possible. Also, the core group is something that is a valid point of yours, that if you have people who do the same thing over and over, they're probably going to have better outcomes, but unfortunately it's not possible because of scheduling issues, as well as Diana said about the after hours and calls and such. You will need to have a lot of more people than just the core group know how to take care of those patients, so as they will be available post hours and so forth, and holidays and weekends. Back to you. Thanks.
Yeah, there's probably an opportunity for some incrementalism in terms of change for policies in certain areas that are very prescriptive, right? If they have X number of milligrams of midazolam, then they have to go here, rather using the algorithm that you just talked about, the Aldrete recovery score, for example. That would be better practice that individualizes to the patient. So just conversations and slow change over time.
Hey, thank you so much for your comments. I think all of you had talked about standards. So I'm an anesthesiologist. I'm also the QI rep, both from my department as well as at my hospital, and we value standards. So the question I have for all of you, as well as for Mr. Thomas, is how do you create standards when the practices of two very different specialties are very conflicting? And that will be, and let me give you an example. It has to do with, say, the food bolus patient. So I know in the GI literature, it abounds with safety with moderate sedation. But then in the anesthesia literature, we consider many of these patients to be a full stomach. So when it comes to developing these standards, these policies, it can be both troubling from a clinical care standpoint as well as from a medical legal standpoint, which is a patient comes in, the exact same patient, if they go to a GI doctor who does moderate sedation, they would get their midazolam fentanyl. They go to a GI doctor who uses the anesthesia team. We now consider them a full stomach, and now we intubate the patient. So I'd like to hear your thoughts about this, as well as thoughts from Mr. Thomas. Thank you.
For the MPO, these are guidelines, they are not standards. If you look at the ASA documents from the 2017, it says those applies for both anesthesia, general anesthesia, as well as moderate sedation. There is another document update to that one. It's called Modular Update for the MPO guidelines. Now we're going to be processed at the House of Delegates in October. If that gets approved and gets published, there is a statement in there indicates clearly that the fasting guidelines should be followed in both general anesthesia as well as moderate sedation. In particular, mentioned there specifically moderate sedation. The fact that patient goes from one area to the other, different services, does not change their status. However, these are guidelines, not standards. We allow for individual variability in making the decision in particular situations, because those guidelines apply to healthy patients, but there are so many out there who are not very healthy, have a condition that would predispose them to increased risk for aspiration. Therefore, the individual decision, if you as an anesthesiologist as a decision maker and telling them, well, I'm going to accept 8 hours and you know I need longer because you have gastroparesis or this or that, or you can go to the other way of doing things, like if you look at the newest ASA guidelines, looking at patients who are very high risk for aspiration with gastric outlet obstruction or esophagectomy case and such, you may want to consider awake intubation as prophylactic for or prevention of aspiration risk and so forth. So there are many ways of looking at it, but again, standardizing things, forcing folks to follow one certain criteria for every single patient, and we know that patients are different, situations are different, what they have ingested is different, so it will be very, very hard. Back to you.
So I think you really hit the issue. It's standard versus guideline. And once you have the standard, if you violate the standard, I'll let the lawyers handle that, then you have a big problem. If you have a guideline and it's a suggestion, you're much better off with that clinical scenario. I think what you're describing is really an issue of judgment, and that, I think if we start to take judgment out of what we do, we're done with guidelines and we're done with our jobs, and sedasis takes over for everything. I figured that would be controversial, but no. But I think there's no way to make it one size fits all.
Yeah, I would wholeheartedly agree with the panelist. There is certainly a distinction in the law, of course. I will tell you, however, there are plenty of plaintiffs' experts, both for the proceduralists or against, and anesthesia professionals that will try to distort guidelines and convince a jury that they are standards. Again, that's our jobs as insurance professionals and attorneys, is to educate the jurors, much as the panelists have noted that these are guidelines and there's clinical judgment that's involved. And through our own experts, of course, we do that quite successfully. I mentioned end-tidal CO2 as a standard. Now, that's a standard in the ASA monitoring guidelines. If we don't follow that, as highlighted in our first case study, that's going to be a problem, and there's going to be plenty of experts who will competently and confidently testify that that was below the standard of care, which of course is the legal standard that they have to establish for one of the elements of negligence. So it's nuanced, and it takes a lot of effort for us to educate jurors, but the good news is that we win out about 90% of all cases we do take to trial with those same types of arguments.
So, yeah, there are a lot of other great questions, but let's call it in respect of the break. People can take their questions individually. One announcement is that I've had a couple of queries about whether the program slides will be available. So this entire meeting will be videotaped and archived. It'll be available on our website along with a PDF of the slides. So people will get that after the meeting. Let's reconvene at 10:15, and thank you all panelists for a great session.